Good morning, everyone. I have a number of questions, and I'll start with HIQA, if that's okay. So I suppose I'd just like you to define your power specifically. I mean, you can carry out unannounced visits. I presume you have organised visits as well to different services. Do you cover all services, public and private? And do you only act on reports? And when you receive reports, and you investigate those, do you document all reports? And then some of them are quite serious. Some of them may be something that can be addressed within the service itself, and that's something that you, I presume, would speak to the management about. But if it's more serious, such as financial abuse, I mean, there was one case there where staff were claiming expenses from the residents' accounts for meals and takeaways and so on. I mean, was that rectified to the residents? Were they reimbursed? Was that reported to the Gardaí? Where there's a case of physical or sexual abuse, is that reported on to the Gardaí or to social protection teams? In relation to SAGE advocacy, I was just wondering, you mentioned there that their work is needed on awareness of abuse, what abuse is. And I presume maybe possibly people will not know how to report it in cases. So what do you propose we should do about that? How is it best to get that message out, exactly what abuse is? And Professor Kelly, you talked about mental health, and obviously our budget needs to increase the percentage of what we spend on mental health. But you mentioned there that it's very difficult to recruit consultant posts within inpatient psychiatry. Why is that? Can you explain why that is the case there? And also you mentioned health and addiction services, that there's still, I thought the dual diagnosis was something that was being addressed and that was proving, because usually if there's an addiction problem, you will have mental health illness, and vice versa. If there's mental illness, there's often addiction, and the two do need to be addressed together. And also you mentioned like the lack of joined up thinking between the different aspects of the health service, and you're talking about individual health identifier numbers. Like PPS numbers, would they not be sufficient to actually ensure that there is joined up thinking? And when you think in this world of IT, that should not be an issue. And just, I suppose, as well on the safeguard and protection teams, Vivian, if you receive a complaint, say, maybe from a member of staff within a service, etc., can you act on that? I've been told that staff have been told no, that you can't. So I'm just wondering, is that true? Okay, or is there something you can do? And all of you have mentioned strengthening legislation around safeguarding, and I suppose I'm asking you as well what that difference that will make to your services, what you do. Thank you.
Okay, who wants to take Pauline's points first? Okay, Carol.
Chair, if that's okay. The Health Act sets out my powers, which is to register and inspect designated centres, and centres for people with a disability is one type of designated centre. And I must assess compliance with the standards and the regulations. It does extend to public, private and voluntary, so there is no distinction. The Act is very clear that it applies to all sectors, and my colleague Finbar can give you some detail around the numbers in relation to that. We conduct both announced and unannounced inspections, and I suppose the purpose of our announced inspections is we would announce those 4 weeks in advance, and that is really to give residents and their families an opportunity to make arrangements to meet with us if they so wish. So we feel that that's also an important aspect. During COVID, we would have had to slightly adjust our approach to announce more inspections to ensure that we can safely inspect services and not put any residents at risk as a result of the inspections. However, so far this year, only 8% of our 325 inspections have been announced, so we're reverting back to the majority of inspections being unannounced. Okay. The regulations require that providers would notify us of any suspicion or allegation of abuse. However, we do take a very proactive approach while on inspection, because really, to ensure safeguarding is appropriate, we need to hear from the people that are living in the centres, find out from them whether their rights are being upheld, whether they're being supported to make those rights real, whether they feel that the care and support that they're getting is dignified and respectful to them. So that's a really key focus. But we also follow up on any allegations of safeguarding concerns, which we take really, really seriously. So I might hand over to my colleague Finbar, if that's okay, and he might outline some of the actions that we take.
Okay. Thank you, Chair. In terms of the number of centres, there are 1,420 designated centres operating in Ireland at the moment. In relation to voluntary or state-provided services, the HSE operate 162 of those centres directly, and they fund the rest of the centres. And in the other centres, there are 734 that are operating under Section 38 of the Health Act 2004, and there are 524 operating under Section 39 of the Health Act 2004. In relation to safeguarding, Carol is correct, we have reverted back to primarily conducting inspections on an unannounced basis, and 80% of our inspections this year to date have been unannounced. During those inspections, we do look at safeguarding in the full sense of that term, in terms of people's rights, quality of life, and also any allegations or suspicions of abuse and how they've been responded to. Where we find that there are inadequate arrangements in place, we use our regulatory powers to require providers to address those issues, and where providers fail to do that, we then take further escalated action where we require providers, we specify what providers need to do, we give them a time frame to do that, or if there's a significant level of risk to residents, we give consideration to cancelling registration. We're very, we're very careful about taking that action, because cancelling registration of a centre causes a lot of distress for people living in the centre, and a lot of distress for people who are important in their lives, like their families, and cause a lot of anxiety as well for people. So it is an action we take very carefully. In 2021, we cancelled the registration of 2 designated centres because we were not satisfied that the provider was addressing the safeguarding issues for residents. But most of the situations that we encounter, providers do take successful action to address the issues that we identify. And across the sector, providers over our period since 2013, whenever we commenced registration and inspection, there has been an ongoing incremental improvement in safeguarding in centres. It's still something we monitor and observe, and last year we found that of the 1,420 centres, we did 1,220 inspections, and community-based services, we found there was a 7% non-compliance with safeguarding arrangements. But in congregated settings, we found that there was a 16% non-compliance rate with protection of residents from abuse.
Okay, thank you. We have Amanda.
Thank you, Chair. I think the question you specifically asked for SAGE was about raising awareness, and there are a number of domains in that regard. For example, the beliefs that we have within our society are contributing to safeguarding concerns. For example, there's this idea that next of kin have a right to make decisions. There's no legal basis for that. There's also a cultural assumption that, for example, families are entitled to money, and you specifically mentioned financial abuse. So, for example, you know, if I'm getting into the will, I'll take it earlier, because they don't see that as extortion of money or anything like that. So it is really about looking at all of those aspects in terms of how we view culturally safeguarding. Also within organisational culture, this needs to be looked at, because many organisations talk about person-centred care, for example. And I teach on that topic. I've never had a student that has come through the course that has said we were doing it right. And at the end of the programme, they would say that they didn't understand it, and yet they have a lovely mission statement. So you have to transform people's aspects of person-centredness, that it's a way of thinking not just something that's lovely on a wall. So from an organisation point of view, that's important. From the individual's point of view, they need to know that they have equal rights and they're not beholden to somebody else, and that there are helping organisations that are independent, because professionals have a particular organisational orientation, families have an orientation and biases. So somebody as an independent advocate would support that person to navigate through what they authentically want and to look at issues such as the variables that are influencing their decisions, if there's any undue influence being put on that individual, if there are ways of thinking that are aligned to, for example, genderised ways of thinking, looking at things like intersectionality of, say, gender, safeguarding disability, and how that impacts on that individual. With regard to the Gardaí, really looking at other jurisdictions in the world, some jurisdictions have developed specific safeguarding in regard to adults at risk. And I'm specifically talking about, for example, the police service in Toronto have specific safeguarding police officers who work in that domain, and they've developed expertise. Also within Scotland, who was the first in the UK to have adult protection legislation, they have developed ways of operating with adult safeguarding. And that knowledge is important because it's not the same as other domains. And while there are overlaps with child protection and domestic violence, it's different, so a different perspective. In terms of addressing issues as a whole, what we know from case after case review, both in Ireland, more related to child protection, but also within the adult safeguarding boards in the United Kingdom or in England, is that there's this continuity of a siloed approach and nobody taking a macro perspective of that and looking at the historical origin and development of cases. So individual aspects happen, but no one is knitting them together and taking an overall view. And the UK have followed this idea of creating a professional curiosity within safeguarding, which I think is important in Ireland, and also had a campaign of making safeguarding personal some years ago. Within our legal system, we need to be able to process these cases, because very often safeguarding is breaking the law, but it's not always brought to that domain because of a number of issues that, you know, family members who are committing safeguarding issues, there is a love-hate relationship. They love the individual, but they hate what they're doing to them. So, you know, in legislation, we also need to have a gateway, to have a right of entry if there's a suspicion of abuse happening within a home or indeed within any environment, and that there is a right of assessment of that person and working with that person, because the welfare of that individual is paramount, not what everybody else says. And that's what we need to keep at the front of our minds, that we're here as the servant of that person, not as their master. Thank you.
Thank you very much. Professor Kelly.
Thank you very much. Thank you very much for these questions. You asked about consultant recruitment initially. Certainly it is an enormous issue. Commonly no applicant for consultant jobs, and sometimes one applicant, leaving very, very little choice in what occurs. It is part of a broader difficulty with recruitment across the health service. In terms of other grades of doctors, in terms of nursing and other professions. But doctors are particularly mobile. So consultants are offered jobs, and we get emails every day about jobs in Australia, New Zealand and other largely English-speaking jurisdictions that are embedded in health services that offer more support, more by way of multidisciplinary working, and therefore more by way of opportunity for professional flourishing. So a lot of the graduates, the people leaving medical school, a great majority of them go directly to Australia particularly, and then it becomes a task not of retaining them but enticing them back, which is something we devote an enormous amount of time to, but certainly a broader health service resourcing, particularly in mental health, would help with that. You asked about the distinction between mental health services and addiction services, and you correctly point out that many people that I see have both problems. So, for example, the vast majority of young men that I see with psychosis or, you know, severe mental illness involving a significant break with reality, the vast majority use cannabis pretty much every day. It is very unusual for me to encounter a case of psychosis or severe mental illness in a young man who is not misusing cannabis at this point. The misuse of cocaine is also very widespread and results in mental health problems. The 2006 policy, A Vision for Change, said that mental health services were to be focused on people whose mental health problem was primary, and that addiction services were to be a separate entity. Now, this doesn't make much sense, certainly in my day-to-day practice. The 2020 revised policy, Sharing the Vision, if I quote, it says, "A Vision for Change recommended specialist mental health services would support only individuals whose primary difficulty is mental health. This recommendation is now reversed." That's the 2020 policy. In practice, however, you can't simply, unite two services just by saying that it is so. A great deal needs to happen to connect it up a little bit more, and that hasn't happened yet, even though it clearly needs to. You also asked about the unique health identifier number, and would PPS not serve that purpose? Yes, one would imagine it would. However, Ireland has gone down a slightly different path, and the HSE, and I'm quoting the HSE website here, under the individual health identifier number section, it says, "Everyone is given an individual health identifier number the first time you use health or social care services in Ireland. It is used to identify each person that has used or may use a health or social care service, and the number lasts a lifetime." So these numbers appear to exist for almost everybody, I understand, in the country. However, for reasons that I don't understand, they're not used in clinical practice. They're not used in day-to-day practice, but there does appear to be a structure there. And this brings me to the final point you made about legislation, which is I'm really interested in initiatives that have been started but maybe not completed. These seem like low-hanging fruit for us to make improvements with. So if we have individual health identifier numbers, and if they exist, it would seem useful to introduce them, even though they don't appear to be the same as PPS numbers for some reason. This is same for legislation. We have a Mental Health Act 2001. There are proposals being scrutinised for revision. These could be revised a little bit and advanced. And I think the College of Psychiatrists of Ireland has made this point elsewhere about the need for revision. And also the Assisted Decision-Making Capacity Act is about to be commenced pretty much in full, I believe. This requires support after commencement. It introduces possibilities for supported decision-making and advanced healthcare directives, but these things won't happen overnight. They need education programmes, they need encouragement, they need rollout, and hopefully we can reap the benefits of that. And there's also a need for dedicated safeguarding legislation, but I guess I'm pointing to the two initiatives that are very much underway and appear, near the finish line, and they would help enormously as well.
Okay. Vivian?
Yes, thank you very much, Chair. I just want to respond to a couple of the general questions, and then I'm going to ask my colleague Celine to deal with the specific one that's related to social work. So many of the issues that have been raised already in the questions overlap in a whole lot of areas, and as Brendan pointed out, to the issues in regard to recruitment within the medical profession are echoed across other sectors of the health and social care professional group, and specifically social workers in our case. So there is a national shortage if you look at the pool of social workers engaged in the various areas that we work. Collectively, there is a shortage in Ireland. And I think two things in relation to that: when initiatives such as new legislation, as we're talking about here, new policies and structures are being considered, there isn't, for example, any national social work strategy in Ireland. There isn't a plan for how government policies will be implemented and delivered where they depend on social workers and where social workers will have to be in place to do that. So there isn't a social work strategy, there isn't a social work workforce plan at a national level that needs to be in place. In terms of strengthening the legislation, it's certainly my own perception that there is widespread agreement that there is a need for adult safeguarding legislation. And you were asking how would that help? In so many ways, as we've included in our written submission. But if I can add to that, I think currently, or in our history to date, we've operated what I would describe as a light touch approach to adult safeguarding in Ireland. Also the approach in terms of services and structured, as has been said already, is extremely siloed. And it's really important that the legislation that we implement in this area as well shouldn't be siloed, because, as Brendan has said, and others I think have pointed out, that legislation needs to dovetail and connect with the assisted decision-making legislation, child protection legislation, domestic violence, mental health legislation, and too often we end up with pieces of legislation as well as the structures that don't communicate and talk with each other. We do have a long and not very positive history of institutionalisation in Ireland. Again, Brendan referred to what I would describe as the history of where we had huge numbers in psychiatric institutions. At that time, we had a couple of hundred people in prisons in Ireland. As one figure went dramatically down, the other figure went dramatically up. And that gap, or that nexus between the criminal justice system and the mental health services is really clear, and is just further evidence of the need to join up the various elements that currently, unfortunately, operate in too much of a silo. So I'll ask Celine maybe to respond to the issue that you asked about how social workers can and do respond to complaints.
Thank you. And I suppose there's a multiple choice answer here, because it depends where the complaint is coming from, where the person is located. If it's a concern from somebody living in their own home in the community, we can access them with permission. We knock at the door and we ask for permission to come in. We have no special legislation or law that grants us access. And while we would look for legislation, we are not looking for that a social worker at any stage can knock at a door and say, I'm coming in to have a look. We do think that needs to be a judicial process, because that is your home is your protected space. If it's coming from a public service, social workers are often employed in many of our public services, so there may be a social worker in the service or the disability voluntary bodies that the person where the concern is raised can access. Where we have significant issues are the private services, and particularly private nursing homes. In the past, we had the HSE Elder Abuse Service, and they would, if a concern came in, would go in, and oftentimes were in many of the private nursing homes. When safeguarding was established, that seemed to make a change, because the process was not direct social work involvement and assessment of concerns of abuse anymore. The process became that the social workers on the safeguarding teams had oversight of what the service was doing to protect people. So there was a significant difference there. So the services, since safeguarding policy came in, so that's HSE funded, Section 38 and Section 39 services are meant to safeguard the residents of their service and let the safeguarding team know what they do. There's a paper process, a preliminary screening that's sent in within 3 days of a concern arising. The safeguarding team review it, make comment on it, ask for more feedback, more information, to ensure that that safeguarding plan is as robust as it can be. But ultimately, that service that report the concern are responsible for safeguarding. So in those services, you may have multidisciplinary teams, you may not. You may have people who have experience of working in safeguarding, of protecting. But for many services, when this was established, there was a very steep learning curve. And I think what HICWA were saying is they're seeing the improvement as services are coming to grasp with it. Training, for staff to recognise abuse has been really, really important. Pre-COVID, there was a training that was provided to all the services, which was 3.5 hours face-to-face training for everybody, which is really, really important that all levels of staff are aware, because it can be the porter, it can be the cleaner, it can be the visitors coming in that will see something. During COVID, unfortunately, training stopped. There is training available on HSE Land, 30-minute video session, which is really useful and accessible for people. But again, that lack of face-to-face training where people have the ability to ask questions has been a concern for us. I think the other concern we had is that during COVID, the lack of visiting meant that there wasn't that family safeguarding piece. Those external eyes that come in and go, what's that about? What's that? Because staff, sometimes when you're in an institution, they do what they're taught, and this is normal. So it takes that external eye to say, how come you're doing things this way? Is there a better way to do it? And Amanda talked about that person-centred care piece. Sometimes when we're talking to staff and you ask them about person-centred care, they tell us about, well, oh yeah, we got a coffee machine in the staff room for ourselves. That was lovely. Whereas we're saying, well, can the residents use the coffee machine? Oh, no, that's just for staff. So again, it's that understanding, the training that we're getting into services about what actually is person-centred care, what is abuse. Abuse is when somebody is being left for a long period of time, that the bell isn't being responded to, that their needs aren't being met. Abuse is when, instead of getting their 20-minute walk in the garden, because they need to use the commode, they're told, oh, well, you're going to have to use the commode, so you miss your walk in the garden today. Abuse is when their money is being used to pay for things that are not to do with themselves. So we've had services that have paid for units to be painted rather than the residents to go on activities, to get new clothes. There's so many small little bits. We know about the big abuse, the sexual assaults, the physical assaults, but sometimes it's the very, very small things. Units where the milk and sugar is still added to the pot of tea because that's the way one person likes it, and it doesn't matter that you don't like milk and sugar in your tea, that's the way you're getting it. So that culture in services is really challenging. If you've got a social worker in the service, that's great. We'd be hoping that they're going to look at these issues, highlight it. Again, very difficult if you're the lone social worker working in a service. Again, you know, we have duty social workers working on our safeguarding teams where anyone can ring in, the guards, members of public, family, services, staff. And if concerns come into the safeguarding teams like that, the safeguarding teams will follow them up, they will contact the service. But again, it's whether they have direct social work contact or not is an issue. So, because if it's a service, they're going to be asked to, this issue has come in, what are you going to do about it? If somebody in the community, the social worker from the safeguarding team will triage it and potentially knock on the door to say, how can I help? If it's a private nursing home, the services will contact and look to engage with the private nursing home, but there is no right of access. They are not obliged to engage with the HSE services. They can thank us very kindly for contacting them, for raising the concern and say, that's okay, we don't need you. During COVID, I would say that there seems to have been a huge change in that, and I think as well supported by HIQA, there's been far more contact, far more working together, really collaborating to make sure that people are safe, regardless of where they live. And that's the really key piece, regardless of where you live, whether it's a private nursing home, public nursing home, disability service, homeless service, a prison, you should have the same rights as everybody else.
Thank you very much.